All right. Let's talk behavioral health. All right. And then we'll go home. Well, we got to do gynecology too, which should take about 3 minutes. Okay. I mean, gynecology is mostly anatomy, and then we're out of here. So pretty much all of the girls can leave, and then I mean, that's fine. All right. So behavioral health. What are we talking about when we're talking about behavioral health? Crazies. Okay. Well, that's one word that we don't use to describe them when we're out there, but yes, people who are having a bad day, right? Special needs, that's a different section. Mentally not okay, but what kind of mental not okay? There's two types, right? Huh? Right, but there's two types. What two types do we have? Well, no, because that would be like a trauma-induced concussion, right, or something, or TBI. But like people who are normal, well, not, I don't like the word normal, but people who are
So like bipolar, maybe?
nope, not an actual definition, but you're close. So bipolar is a what kind of disease?
It's a mental illness.
It is a mental illness, but it's a what kind? You have two
Psychological.
kinds. That's the same word. We're using the same word for everything.
Functional.
You guys aren't getting it. Emotions come into this, right? Emotional disturbances are more of the first type than the second type. What two types of what two types of the disease processes do we have that we deal with in EMS? It could be anything. It's the most broadest, most general terms. Right. Well, okay, but let's go beyond that. So like you have medical emergencies, you have two types, right? What types are they? Everything else is classified, but you have people who are on dialysis have what? Right, but it's considered a what type of disease?
Like chronic?
Right. So we have chronic illnesses. Okay. So you can have people who have chronic mental health disorders, right? Oh, and you can also have what's the other one? What's the opposite of chronic? Acute. All right. So you can have John who, let's say his wife leaves him yesterday and his job fires him this morning, and now he's feeling a little emotionally upset. That's an acute response, right? John doesn't necessarily, and I don't know, and I'm not going to put it on him, but he doesn't have any mental health disorders that we know of, right? He may or may not. We don't know. We'll find out. We'll ask questions. Okay, but we would consider that an acute, right? Mental, emotional, more illness than like someone who is chronically schizophrenic, bipolar, all right, panic attack disorders, all right, all the other good stuff that we deal with. Okay, so let me turn my thing back on. Nope. That could be acute or could be chronic. It might not be the first time that's happened. It may be just the time that caused him to lose his mind that day, right? So, but yes, that is, like the crimes of passion are more acute, right? Versus something that's been going on for a while. So, okay, we just talked about that, right? Not everything is a mental illness. Okay, some things are emotional. Okay, don't just go by what you've heard and be like, oh, they're on the crazy train. We're just gonna forget all about it, right? And the same thing can happen with your chronic psychological patients. All right, some days they're having better days than others, and they still want to call and talk to somebody, and you're just going to kind of like, sometimes you get a little dismissive because you're like, I don't have time for Jamal today. Like, I'm all set, I'm done, just get in the truck, let's go. And like, but he's really having a problem and needs help. Okay, so mental illness is not considered a sickness. All right. Again, depression is a real thing. All right. We allow people to feel depression. Don't just try to like, tell them to suck it up or work their way out of it. Right. There's 5 stages of grieving, especially for dead people, for deaths. All right. So let people go through the stages naturally. All right. And very, very not often are people dangerous, violent, or unmanageable. Okay. Like I said, I can count the number of times I've had to sedate a patient on one hand, probably. All right. They're not always violent. They can usually be redirected or talked down. Because he was bat crazy. I mean, so, well, I don't really know what happened, but when I got there, he was in a straitjacket. So that was clue and warning sign number 1 that this small dude about your size was in a straitjacket. And I was like, okay. Then I literally watched them give him a, what we call in the business, a B52, which is 100 milligrams of Benadryl, 2 milligrams of Ativan, 5 milligrams of Haldol, and literally watch this dude shrug that off like it didn't. Most people within the first minute go night night. This dude, the opposite. He just got more hyped, and I was like, what else are we gonna do about this? Like, we got some ketamine. I think some, excited delirium. He's got to be on something. So like, no, he'll be fine. We'll secure him to your stretcher. So security came and somehow secured him with the straitjacket to the stretcher. And they were like, if he needs something, like give him some Versed on the way. And I'm like, sure, whatever. So this guy's talking to me the whole time and he's squirming. And at one point he got one arm out of the straitjacket. And I'm like, this is a no. This is a no. And so I hit him with 10 of Versed, and this is on top of the B52. And he's still going, like, just doesn't phase him one bit, ready to go, ready to fight. And I'm just like, nope. And he was about to get the other arm out. Like, he had the buckle almost undone and was ready. And I was just like, here's some more ketamine. And finally, like, he was out for about the next 10 minutes, which is what it took us to get to the hospital that he was staying at or going to stay at. And that they knew him on the floor. And then they wanted to argue with me as to why he was in a straitjacket. And I was like, well, here's all the medications he was given. He was in the straitjacket when I got there. I am not allowed to take him out of the straitjacket, so he stayed in it. And they're like, well, our security guards aren't allowed to take him out either. And I'm like, well, I guess he's staying in it for a while. And I don't know what to tell you. I am not going in the room. I go, this man has had more sedatives that should have knocked out a fleet of horses, and he is still going. I go, he's in the padded room. He's running around bouncing off the walls. I was like, I'm not going in there with him. You guys can figure that out. Like, I would just let him do his thing until he tires out and, passes out, and then you go whatever. But yeah, no, like, and I literally dumped all of my narcotics, sedatives into him, and nothing. I don't know what he was on or what he was doing or what kind of tolerance he had to whatever, but he was, he was first one that ever had me nervous. The other one was 65-year-old dude. He was about 6'8", looked like what's his face? Looked like George Foreman. Like, built, strong, put his hand back and like swung at me and stopped like right here and then just goes, ha, ha, ha. And I said, ha, ha, ha. It put grandpa to sleep. I was like, because you don't have swing at me, stop right here next to my jaw and just laugh at me without me going click. You're done. I'm all set. I'm like, grandpa almost just cold cocked me in the jaw. Like, and he was a big dude. He probably would have knocked me out at 65. Like he looked like he had boxed his whole life in the city of Baltimore. Like he was a fighter. Like he was ready to go. And I was like, no, grandpa, no, we will fix this. So I get there and the nurse is like, why is he sedated? I was like, he's a fighter. Just watch. What do you mean? I go, yeah, he likes to like sucker punch. Like, I mean, he was just laying on the stretcher and I leaned over to grab him something and he just like whoosh, swung at me. And I was like, oh. And I was like, not again, sir, not again. But yeah, weird things happen. Okay. So again, only a small percentage. All right. You will probably be exposed to more violent patients because as medics, we don't handle psychology patients or behavioral health. We automatically, unless they're going to get sedated, just it's an EMT thing. So just be prepared to get all of them shoved on you for whatever reason. But like I said, most people you can talk down, right? If you're just calm, understanding, right? Don't fight into what they're doing or don't try to bring, agitate them or instigate them or try to make a joke out of what's going on. All right, everything will be a lot easier. So behavior, right, is the actual response to the physical stimulus or the environment. Okay. So as we grow up, as we watch our parents deal with stress, as we deal with our own stresses, okay, in our social environments, we all come up with personal ways of coping. All right. And sometimes that stress gets so great that it just cracks the dam, right? Think of it as a dam and just the water building up and crashing and crashing and crashing. And then eventually, right, the dam gives way. And that reaction to that acute stress or that acute situation, all right, is basically what we're being called for. Okay. So they can include patients who exhibit any type of agitated, violent, or uncooperative behavior. We're going to really focus mostly on the danger to themselves or others. All right. We can't leave people in the house if they're assaulting other people in the house. All right. We kind of have to, along with the police, make a decision on what's best for everybody. All right. And then we handle whatever decision we make is what we're going to do. Sometimes the cops don't want to get involved. Sometimes the cops will fill out paperwork. Sometimes they'll arrest them and then the cops come with you. Okay. So once the behavior lasts for a month, then we can consider it to be more of a chronic behavior. Okay. And that's when like physician intervention probably needs to become involved. All right. They should either be talking to people, being medicated, maybe being in therapy for a couple days a week or whatever they decide they need. All right. Again, it's always about agitation, violence, or threats. Okay. So anxiety is the most common psychiatric disorder that we're going to deal with. Okay. And anxiety is going to mimic a lot of other medical conditions, which is why it's kind of hard to discern anxiety versus like a cardiac chest pain or difficulty breathing. All right. And these are the types of anxiety disorders that you're going to see. Just a generalized anxiety, panic disorder. Panic attacks can actually mimic like heart attacks sometimes. People literally just start freaking out. And you have to, most of these people will know how they work themselves out and work within that with them. Okay. I had one who, I don't know if I told you this, but she was pregnant and she had COVID and one nurse told her that COVID causes either preterm stillborns or like preterm abortions in all pregnant females. So like, and she has a history of like anxiety and panic attacks. I understand that. I don't know. I like literally had to fight with this poor young woman about how this lady was like lied to her in the clinic. Right. But that's what she was told. So she came home and she started having a panic attack and literally like freaked herself out to the point where she had chest pain, abdominal pain. She was like, I can't feel the baby moving anymore. Like literally had convinced herself that the baby had terminated inside and was like, I need to go get it, make sure that it's still alive. And I'm like, okay, let's go, whatever you need, right? So she's in the back and she's tacking away at like 160. And I'm like, well, I don't want to give her meds because that goes to the baby. All right. So I'm like, listen, I'm like, calm down. Let me look, here's all the research. Like, I'll show you on my phone. Like, this is not a thing. I don't know where she got it from. All right. But it's like less than 1% of pregnant people. And that's better. That's less than what the actual like stillborn chance of stillborn is. I was like, so, right. I'm like, she just said some dumb thing. I don't understand why. Right. I was like, so how do you work through your panic attacks? Like when you have one at home, what do you do? And she's like, well, I put ice on my forehead. I'm like, great. That's a vagal response. Let's do it. All right. That'll do exactly what I want. It'll bring the heart rate down. So we put 2 ice packs like right here on her forehead. And I was like, I gave her some oxygen. I was like, just breathe in through your nose, out through your mouth, real nice and slow. And her heart rate came down and her blood pressure came back up a little bit. And, you know, she started feeling better. She's like, oh, I think I just felt the baby move. And I'm like, yeah, because you're not all worked up. Right. But like we worked within her structure, like her coping mechanisms, okay, to make her feel better. And that's kind of what we have to do. Right. So there's, oh, it's calling me. Hold on a second.
Did anyone do anything interesting on their break?
I have COVID.
Was that interesting?
Um, it's becoming less interesting. but I just thought that would be a news. What about you?
Trying to think, because we had some COVID news too. I don't remember all of the particulars. People at the school had it. And then my kid sneezed in front of a teacher and got sent home. Another kid yawned in front of a teacher and got sent home. So that was kind of weird. Oh, I got my booster. That was different. That felt unpleasant for like a day.
Oh, what happened?
Oh,
What
we,
did I
you know,
miss?
somebody got COVID,
Oh,
but they're getting better. All good.
well, that's good. Everybody has COVID right now. Just don't take the test so you don't know if you have it or not. Why? What's the difference?
That's how the Memoths get killed.
That's how the memes get killed. I mean, are you going to do any other than staying home? Are you gonna do anything different, whether you know you have it or not? Are you going to attempt to heal any different?
I get paid to stay home if I have COVID.
Huh? What's the treatment right now? Right, I don't know. I don't know. Yeah. It's like, I don't- Okay. Like ventilated or something, right? But that's what I'm saying. Like, so people are still gonna go to the grocery store even if they have it because it just feels like the flu. People don't care. They're gonna put their mask on. They're gonna go because the CDC says that they don't care anymore. They just came out and they said it's because of the shortage in nursing staff. Like if nurses with whatchamacallit, nurses who are testing positive, as long as they're asymptomatic and feel like they can work, can still report to the hospital. So the nurse who's taking care of you in the hospital could possibly be COVID positive as they're taking care of you, and you have no clue. But the CDC says it's okay. Right? They just came out with that one. So like, what are we really doing with COVID nowadays? You know, it's just like, do you want to know or not know? Do you want that extra anxiety of knowing that you have COVID, or do you just want to have the flu and get over it? Right? So there's also PTSD and OCD out there, obviously. We'll talk about PTSD later. Okay. We're getting better with mental health these days. There's a lot more resources out there for people. And now we're finding that there's starting to be not enough resources out there for people. The psych centers in the hospitals are starting to get overrun, especially during COVID. They seem to get a lot busier than they used to be. So we're trying to take it a little bit more seriously versus just like before, when we really kind of weren't thinking it was a thing. Again, most times we will hospitalize them quick for the acute version. Okay. And then if they get diagnosed, they will handle the rest of it through outpatient visits. It's not something that requires multiple hospitalizations. Unless you're a teenager who likes the attention and feels like they get a vacation from mom and dad in school. Because I've had a couple of those. The one I wanted to take mother aside and be like, I think you're the one who needs counseling. So she's got like a 14-year-old son. Her and her husband just got divorced. The new boyfriend already is there with the mother at the hospital. We're taking the kid to a psych center. The stepdad, we'll call him, brought McDonald's breakfast for the kid because it was like 5 a.m. And he hands it to her and he's like, here you go. She goes, no, you have to give it to him. They're like dogs. You have to be the alpha and give him his breakfast so he knows who's in charge. And I'm like, and this is why this kid wants out of here. I'm like, because you literally just told him he is a dog and needs to learn his place in the pack and it be trained. And I'm like, why are we like, this is why this kid has problems, right? Like, you need to come over here and have a discussion because I think when you work out your issues, he will work out his issues. But, you know, there's some interesting people out there. Okay. So again, you know, we'll talk about the different underlying causes such as stress and schizophrenia, physical illness, right, can cause acute behavioral disorders, obvious alcohol and drug use. Okay, mostly talking about withdrawal. And then simple things such as electrolyte imbalances. Remember I told when we were in diabetes, I told you about the one girl in cooking school, right? Like she would literally, we all thought she was bipolar until we told her, or she told us she was diabetic, right? So what is your job? All right, your job is not to diagnose why they're having the crisis. Okay, you need to understand whether it is an organic or whether it's a functional disease. All right, what's going on? All right, so an organic disorder, all right, is a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or physiologic functioning of the brain. All right, so these are not emotional responses. All right, these are sudden illnesses, TBIs, right? Seizures, drug and alcohol abuse, withdrawal, overdose, like bacterial meningitis. All right, the one, oh, I don't even know what this guy had the other day, but he had lesions on his brain from some bacteria that was literally eating away his brain. And he had like, there was like one antibiotic that he had to take every day in order to like keep it from eating anything more. And the nursing home he was in was having a hard time getting it because it's like such a rare medication or something. We had to take him back up to Albany Med so that he could literally take this one medication. Right. But like, you know, he was all over the place. He was kind of, and I don't know if that was an organic thing or if that was a little mix of both. Right. But he had a disease in his brain. So it could have been. Right. So the altered mental status in these will come mostly from, again, hypoglycemia. All right. And we all know that people can get angry and vicious and violent with their sugars, either high or low. Hypoxia, again, causes altered mental status. Some sort of impaired cerebral flow, right? If there's increased intracranial pressure or swelling. All right. Some of the blood vessels may be cut off for, you know, whatever reason. All right. And then just hot or cold. Okay. Functional disorders. All right. Is the psychological disorders that we can't figure out because the body seems to be normal. All right. These are your chemical imbalances, right? Your schizophrenia, your anxiety, your depressions. These are all the ones where there seems to be no physiological reason why there should be something wrong, and yet something is still wrong. Okay. So organic has a physiological cause and functional has no physiological cause. All right. So basically, we are going to do everything that we normally do, right? I would have a behavioral crisis if my room looked like that. I would literally, yeah, I'd be freaking out too. I understand, you know, not everybody can live in a mansion, but like, I don't know what all that white stuff is in the carpet. The carpet's ripped up over there. The wall's coming apart. Like, there's a bucket. What's the bucket for? Is that the toilet? Like, right? But I'm just saying, like, I would, you know. So the injury pictures are all real. These ones I feel like could be staged. I'm not too sure like how many people are going to let them take a picture of them in their room like that, but you know, it depends on like what is this, you know, like a factory floor, right? That they goes off and it's just like, you know, like a set stage kind of thing. I don't know. Okay, but the most important thing is when you go into someone's house, and this is why I ask you questions like on Mr. Klein, is you better know the way in and you better know a way out. All right. It doesn't have to be the same way you came in, but as you're walking through, make sure you can find another way out if you have to. All right. Because you never know what's going to happen. More people could show up and block you in. All right. More people can come out of nowhere that you didn't even know were in the house. All right. So this is why we have police there. Let them clear the house. Let them find everybody. Let them put everybody in a safe place before you go in. Okay. And the only thing missing from this picture is the officer who should be standing right here by the blue dresser. All right, because that is where I usually like my law enforcement in the room with me. All right, so that if he does start to do something, either I can push him towards the officer is within arm's reach to grab him. All right, like something between the two of us that we can take care of everybody there. All right, but yeah, the cop is missing. Okay, so again, an acute psychotic episode. Okay, could be any type of mind altering substance, right? Any, like we said earlier, John's emotionally distraught morning that he had over his wife leaving him and his job getting fired, right? Any type of intense stressors. Okay, maybe you're not doing so good in school and there's 4 finals next week, right? And you guys had that at the end of your thing, and right, maybe some people didn't handle it as well as others. Okay, sometimes people just get delusional. Sometimes they have delusions. Sometimes they will see, hear, and talk to people. All right, just don't get sucked into the rabbit hole with them. But if they ask you if they can bring George, you feel like, sure, George can come. Like, is George going to hurt me? Right? But like, don't sit there and start conversing with George, because then you're feeding into it and you're not right. You're not helping them any. Okay, and schizophrenia is one of those where it's like an on-off switch. All right, so you got to be careful with schizophrenia. Okay, it usually comes on in the mid-20s. All right, and it can be, they find mostly genetics. Quite often comes after a TBI. All right, and there are some social influences to it, but all right, again, delusions, hallucinations, all over the place. Like literally have no discernible train of thought. They will just start over here, go over here. It's almost like the squirrel kind of scenario. All right, and nothing is fun for them anymore. There's no activities or things that cause them pleasure, right? It's just they're there and they're just there every day. All right, so again, as we do with any scene, right, we're going to do scene safety. Okay, most behavioral emergencies, cops will go automatically with you. It's just the thing we do these days. All right, again, be clear, be calm, be direct, be straightforward. All right, do not become emotionally involved in the scene. All right, I had that happen last night, and thank God my partner yanked me out of it, because I felt bad for the wife of my one cardiac arrest at 2:00 this morning. He had just got home from the hospital. She had put him in his favorite chair. He had been wanting to come home for like the last 2 days. All he talked about was being home on the farm. He wanted his dog. He missed his dog. And the last time they saw him, they put him in his chair in front of the TV next to the fireplace. At 10:30, they gave him a cup of eggnog. They said he drank his eggnog and he fell asleep. And then they went to wake him up at 1:00 to bring him to bed, and there was no pulse, no breathing. Right. So somewhere between 10:30 and 1:00, it could have been 10:31 and it could have been 12:59. Like, no one knows. Right. So they started doing CPR. The cops started doing CPR. He was in asystole when we got there. His hands were super pale. His face was gray. Like, it didn't look like it was going to be a good thing. He had a port for dialysis, so that was nice. I didn't have to waste time. I could just use the port to give him the medications. And we worked it for a half hour, and we had the Lucas device on, so nobody was actually doing compressions. It was mechanical, right? So I was like, all right, go get the reusable transport, because mom's wailing in the background. And she's like, I took care of him. I did everything. Like, what did I do wrong? And my partner's like, hey, he's been in asystole for like 30 minutes. Like, why are we going to take this? And I was like, well, it's more for the people around like here. Like, I want them to know that we did everything and yada, yada, yada. And he's like, you know, they're going to be mad at you because every hospital is at capacity. And if you bring this and you make them work this for 20 minutes and they have to call it, they're going to flip out. And I'm like, yeah, you're kind of right. He's like, I know what you're trying to do. He's like, and I respect it. He goes, but we have to call it here. And I was like, all right, let me go make a phone call. And I went outside and I made the phone call. And then I had to come back in. Then I had to have that conversation. And they're like, but he was fine. We just took care of him. You have to take him. Vassar can fix this. I'm like, no, Vassar cannot fix this. Right. But like, again, now I have to help the wife through her initial stages of emotions. And, but yeah, no, I got inside my head a little bit and I was gonna transport the patient just so that the wife felt better. And, my partner talked me out of it. We made the right call, but sometimes it's a harder call to make than others when you kind of got to look the family in the face and tell them that, it's not a good day. But so again, we don't argue, right? Don't get into whatever hallucination or delusion the patient's in. All right. Tell them what you're going to do. Tell them what you expect from them, to keep everybody safe. All right. And then if there are patients or if there are people there who the patient has a better rapport with, use them. Like, use family and friends to help you. Use the cop if they're already friends with the cop because the cop's been in the house 100 times, right? Use all of the things around you that are available. Okay. Delirium is basically another psychotic episode, all right, that comes with the same thing, except these people have like gorilla strength. All right, these are the ones that like you could be 5'2" and throw a 6'10" dude through a wall. I don't understand it. I don't know what happens, but like they all of a sudden gain access to every bit of strength in the known universe. And I have watched 3 grown state troopers try to wrestle a little girl like Gianna to the ground, and she is still winning. And I'm like, I don't even understand what's going on right now. But sure, hold out an arm long enough for me to get this in, and we'll figure it out. Right. But
And I can't remember why she had to go to the hospital, but they were basically forced. And what the people did there is they lied to her and said, "Oh no, you're not going anywhere. Just leave the trailer." And then she got there, she was like, "What are you doing? For taking your husband?" She flipped out and was like, "No, they lied to me. They said that." And then we didn't even need to try anything. We weren't told that she wasn't supposed to know. I don't know why they lied to her, but she started freaking out and then almost started punching us.
Mhm.
And then the nurses that worked there like ran upstairs and started holding her down and said, "Oh, I couldn't believe how strong she was though. Like it took it was 4 grown men, 2 of the nurses who were female with me. I was the one tying her because the son was going. But they were all holding her down and she was almost winning. So
yeah, I don't understand it, but I don't know where that strength comes from. Okay, so just be careful. Again, be very, very careful. All right, these are going to be your hyperactive people. It's going to be super irrational. All right, if you can get a blood pressure or a pulse, all right, they will be hypertensive and tachycardic. They're probably sweating. Their pupils are going to look like dinner plates. Okay. Now, this whole chapter is the one time that you can forego getting a set of vitals, and you can write in the chart for your safety and get away with it. All right. You can literally put them on the stretcher, not touch them, take them to the hospital, and you could be like, for everyone's safety involved, like no interventions, no assessments were made, blah, 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 blah. And you can be okay. Because again, right, you don't want to agitate them any further. All right. So we were talking a little bit earlier about this, and this is the basic mantra of the entire chapter for everybody. Okay, is be calm, be supportive, be empathetic. All right. Respect their personal space. Again, limit physical contact unless they're okay with it, right? Ask them everything, ask their permission for everything that you want to do. Okay. And these ones, yeah, you definitely don't leave them by themselves because you may lose them. They may just run off. All right. They get a little skittish. All right. More about what we're going to do here is more about the history and the interview. Okay. You want to assess their cognitive ability. All right. You want to determine their ability to communicate where they are during in their psychotic break. All right. Again, their appearance will help you with that. All right. If it's early on, they may still be okay. If it's been a couple days, you're gonna notice that like unshaven, unkempt appearance, maybe some wild hair. Uh, if they haven't taken a shower, there may be a smell. All right. The clothes may be dirty, especially if they were outside. All right. If it's due to an overdose, again, if you have the ability to take all the medication bottles, I do not recommend taking illegal substances to the hospital. They're not very happy about it when you hand them like bags of cocaine. Okay. Because then they have to figure out how to get rid of them. All right. But usually the cops will handle the illegal stuff for you and then they can tell the hospital because they're going to come with you. All right. The most important part again is take them somewhere that has behavioral health abilities. Um, which around here is Kingston Hospital and Mid Hudson. There was a countywide emergent order saying that you could take them to the nearest facility to be evaluated and then they could be transferred, um, which is fine. Just if you have the ability to take them somewhere where they can be seen right away instead of wasting more time because it's not a quick process. Right. These are the people that sit in hospitals for like 14, 18, 20 hours in the ER because there's no available beds in a psychiatric facility or, there's no psychologist for them to talk to. And it's really not fair to them because like the ER is no place to start healing either. You know what I mean? So um, try to take them where you can, the right place. All right. And I know like if you've ever gone to the hospital and been into one of the behavioral centers, they're not also like the best place to try to heal mentally. They're locked. They're usually you get a cubicle with nothing in there. Like you may get a mattress and a sheet. They take all your clothes, they take everything, they put you in a gown, they take anything that has a string on it, so you can't like choke yourself. Right. I understand they do it for your protection, but again, it's like it's almost like a detention center. Like, and I don't, it's not until you get put in an actual facility where the surroundings become a little bit more comfortable, we'll say. But um, again, especially in the excited delirium, like we don't mind sedating people. All right. So call ALS if you have to. And then just be careful because depending on what they're excited from, it can cause sudden death, especially if it's an overdose of some kind of drug. What time is it? Is it break time yet? Almost. All right. So restraints are um a touchy subject. Okay. Uh every agency I think has their own version of restraints, what they use, if you're allowed to use them or not. We as EMS providers at the EMT level only use soft restraints. All right. We don't use any type of hard handcuff, anything like that. That's all the police. Um, and most oftentimes, if we do, hopefully it's chemical because that's the safest way for everybody. Okay. Um, we'll show you how to tie them up appropriately. Okay. There is a special way that you restrain people. All right. And again, if it is a non-emergent or they are not hurting you or someone else, like, all right, just be careful because you will be sued and it will be assault and battery. They can get you for false imprisonment and civil rights. Okay. So this is why even at the chemical level, ALS providers are very leery about sedating people because, right, without at least the consent of the cop who's now taking custody if they're being arrested, right? Like you have to be able to explain how you thought in such a way that this was taking their consciousness basically away from them for a while, right? And how that's a good idea. Okay. So this guy's having a hard day. And you can see the soft restraint down here on his wrist. All right, and we use the buckle straps, even though that's the first one they always get rid of. Okay, because it's just a seat belt, so they can click it. Usually, what I will do is I will alternate how they're wrapped. So we put them in a wrap, and the first seat belt will go inside the wrap, and then I'll put a blanket over it. And the next one goes outside it, and then I'll put a blanket over that, and then inside again. So there's like layers for them to try to get out of that gives me time to react before they're out of all three straps and doing whatever they're trying to do. Okay. So most oftentimes we can get away with just the seatbelts and wrapping them up in blankets. But if we actually have to do physical restraints, okay, law enforcement will come. They will handcuff them. We are not allowed to transport handcuffed patients behind the back. The cops know this. All right. They are supposed to, once you get in, take the handcuffs off and attach them to the arms of each stretcher. Okay. So that they're attached to the railing of the stretchers. Okay. But you can't have them sitting there with their hands behind their back like this on a stretcher. All right. It's not safe. It can cause more injury. All right. Huh? The cops know this. They should know better. All right. The cop cannot also toss you the keys to the handcuffs and say, here, you got this, and I'm going to bring my car. Okay. Like, because I've had that happen to me one time and I tossed them right back and said, no, sir, you know how this works. You'll go get in. He's like, well, I won't have a ride back to my car. And I said, that's not my problem. Like, if he's going in cuffs, you're sitting in here with me. He's like, really? You're going to do this? I'm like, yeah, this is this is the rules. Like, he goes, I'll show you how to take them off. I'm like, no, I know how to get them off. Like, I get the key system. Like, no, this isn't happening. Right. So yeah, just be careful. All right. Don't get yourself in trouble unnecessarily. Okay. Again, this is how we're going to restrain someone. Once you decide, it should not take you much more than hopefully 2 to 4 minutes. All right, to restrain somebody. Hopefully you have 5 people. Yes, there should be one for everybody and the head. No, we're not headlocking people. Okay, it's just to keep them from possibly biting other people. All right, try to hold them like you would C-spine somebody and kind of try to maintain their head this way. All right. You should have one person in charge, one person giving instructions. Okay. And again, this is arbitrary, but the minimum force necessary. All right. Like she said, the girl at the Astor home or whatever required 4 grown men, 2 nurses, and 2 EMTs. That seems a little aggressive to me, but it's a possibility, right? So use the minimum force necessary to keep everybody involved safe. All right. So again, I don't necessarily agree with the patient's sex, size, strength. I definitely agree with mental status. All right. But size and male or female doesn't really matter. Okay. If they're excited or if they're at the point where they're being restrained, they're going to have the ridiculous level of strength. All right. I guess my nephews were never really bad. They kind of got dressed by themselves all the time and they never really threw tantrums about putting pants on. I guess, maybe. Is that it? Is that the secret, is to not be the parent? Hmm? Okay. Again, we're gonna talk the person through the entire process. They're probably not gonna process it, and they're not gonna understand it, and they're not gonna be happy about it. Okay. There's really no good way to restrain somebody. Um, just maintain their dignity and respect as best as you can through the whole thing. Um, and again, as long as everyone is comfortable and feels safe, um, the same genders should attend the patients. All right. So female to female, male to male. Like, I'm not saying that anybody would ever do anything, but if you put a male in the back with a female restrained patient and they say that he assaulted me on the way, like, how do you prove that he didn't? Okay. And that just gives yourself more chance of liability than you want. All right. So it's more, we do it more for protection of ourselves than we do it for the patients. Okay. But sometimes it makes them a little bit more at ease as well. And I would definitely wear goggles and or face shields because they will spit and they will continue to spit until there's none left. All right. And I don't always recommend putting something over their face, although sometimes it's necessary. Okay. Um, I don't know about the direct eye contact. Definitely respect their personal space. Um, Sometimes direct eye contact can be considered a threat and like will egg them on. And other times you can almost have that non-verbal communication between two people where like you're gonna behave and you're gonna understand that I'm in charge and you can do it all through your eyes and they get it or they don't. Right. So sometimes you can look at someone and that's all you need to do. And other times that just sets them off even more. So you're kind of going to have to uh, feel it out a little bit in that situation and know which, like, where you're at and what you can get away with. Yeah, you'll know quick. Right. And again, we don't leave restrained people unattended because they can hurt themselves. It's called abandonment, and we talked about it. All right. And most oftentimes we will do all four extremities because once you have the hands down, they can still kick you. All right. Most of the times you can do the legs with the seatbelts and get away with it. But if they're that agitated, then you should use cravats and tie the legs down, which sometimes they're so strong they break them and they rip them, but it doesn't. You'll figure it out. It's not a science. Okay. And again, airway control once you have them restrained. All right, because once they vomit, they can't sit up, they can't do anything. All right, so we're gonna make sure we reassess them and we go from there. All right, let's take 10 minutes. Should be close to 7 by now. Take a break and then we'll come back in 10. Huh? I don't know where we at. We got a little bit left to go, right? We didn't get to, yeah. I at least want to get through PTSD because that's important. And then we'll go after that. We'll decide if we're gonna do the rest of it or not. You know how much extra like it makes the bag like this much thicker? It's ridiculous. It really doesn't. It's just me being whiny about it. Yeah, pretty much. All right, so let's get back into this. Depression is the number one cause or factor contributing to suicide. Okay. People who threaten suicide it's a cry for help. Okay, but it doesn't mean that they're not going to do it. All right, we take every suicide threat seriously. All right. These are not people that we will RMA and leave alone. Okay. Even if we don't think it's a real, and that should be the worst thing you ever do is think that like it's, the cry wolf scenario. All right. Cause it might be up until the day it isn't. All right. And you don't want to be the cause of the day that it is. All right. So immediate intervention is always necessary. We will always take them to the hospital, whether we do it or the cops do it. Someone, all right, the cops will probably 941 them and make them go to the hospital and make them stay for a couple days. All right, it is not something anybody takes lightly anymore. Okay. Um, warning signs. Okay. A lot of excessive crying, tearfulness, sadness, deep utter despair, hopelessness. Um, people start giving away their possessions, or like having you come over and be like, oh, you like that? Go ahead and take it. And it's like, but that's something you've loved forever. Yeah, yeah, go ahead, you take it. I want you to have it. All right. Stuff like that, like be aware of. Okay. Again, don't necessarily avoid eye contact, but don't give them the like stop your crap glare. You know what I mean? Like that parental glare, like be sympathetic with your eye, like with your eyes. I don't know how to say it properly, but you kind of know the emotional state you should be in for these. All right. Um, oh no, they will avoid eye contact. This is them. That's right. Okay. They may not have plans for the future. All right. They may have written a plan down somewhere. They may have a plan. They may have a note. All right. They may make hints or light of suggesting it, or they may come flat out and say it. All right. Um, any of these are risk factors for suicide. Okay. It doesn't necessarily have to be an ongoing thing. It could be an acute thing, right? So depression, previous attempt, all right, and then again, were they previous? Like any attempt is a previous attempt, all right? Someone may have cut their wrists and they may only break the first 3 layers of skin. That's still an attempt, okay? That's still cutting. They cut themselves, all right? Did they go all the way down as far as they should have? No, right? Were they really trying to do it? Who knows? Okay, but it's not something we take lightly. That's not for us to decide. All right. Again, if they have a specific plan, all right. Older people are at higher risk again because they of things that have happened to them through their life. Certain like more depression based on illness, finances, whatever. Okay. A lot of people, and I am definitely probably one of these people, but if I ever get some sort of chronic debilitating illness or like some sort of fatal diagnosis, like I may take a walk in the woods and I might not come back, right? Because like I'm gonna go out on my terms, right? But like, and I say that and I have made joke about it, but like, when it's time, we'll see what happens, right? But I don't know. I don't want to lay in a hospital bed for like 6 months and be dead, like and dying. Like that's not something I want to do. Like, I've always told my parents if I have no chance at quality of life, like pull the plug. Like I'd rather go. I don't want to be in bed with a trach, like on a ventilator, and just be able to like move my eyes around and stare at people walking around all day. Like, no, that's not it, right? But I mean, that's people make their own decisions. Okay. Very dramatic mood changes. Okay. Alcohol abuse. Um, again, that withdrawal from family, friends. They're always like the social butterfly, and all of a sudden they become a shut-in. Um, certain anniversaries, okay, can cause depression. Uh, and then obviously, if they go out and start buying a whole bunch of guns, and they're not like people who use guns or want guns, like they have a plan of something, right? They're either stockpiling for the annihilation or something else is going on. So just be aware of your scene surroundings, okay? Um, family members, if you hear any of these things, like family members talking about these things, right, it should ring a bell. Just kind of worry about them. All right. Again, scene safety is our utmost importance here. All right. Is there anything that they can get us with? Is there anything they could get themselves with? All right. Is there evidence that they've tried? Or is there a bloody knife in the sink? Okay. Is there blood on the floor? Are there pills somewhere? Are there empty pill bottles? Right. Do they have like powder on the side of their mouth? Right. Or is there an imminent threat to everybody around? All right. Do they have medical problems? Right. Are there cultural or religious beliefs? Has there been trauma? Right. How many times have we heard, right? Like person will come home, grab their family, right? Kill their family, then kill themselves. Okay. So suicidal patients may also harm others. All right. So you got to be very careful. Keep PD nearby. Right. They may want suicide by cop. They may want the cops to end it for them so they don't have to. All right. So they're very tense situations. Okay. And just got to work within what the scene allows you to do. Okay. Just be very careful with suicide patients. All right. So PTSD and combat veterans, this is kind of important as they're coming back. All right. Years ago, we didn't really care. Right. The Vietnam vets, they were kind of shunned. They weren't really taken care of. They had a lot of things going on. I know when I first moved down to Maryland, I worked for the VFW, and he would tell me stories. And there are nights where he goes out to the graveyard and he sleeps in a graveyard because it's the closest he'll get to his friends who died in Vietnam. And that's where he feels safe because he goes, who's going to come into a graveyard and mess with somebody sleeping? Right? Like you have to be just as crazy to come into a graveyard to mess with somebody who's sleeping on the ground next to a grave than you do to be out there sleeping anyway. Right? So he felt safe out there, and that was his thing. All right. But like when you think about it, what has to change you on the inside at such a personal level that sleeping in the graveyard is your new normal? Right? That's what makes you feel comfortable. Okay. So like these are the types of things that we're dealing with these patients. All right. And there could be any type of assault, abuse, accidents. Okay. Doesn't have to be combat veterans. All right. So could be natural disasters, right? People who go through hurricanes and lose everything, right? Tornadoes, uh, monsoons. What's the other one? The waves that come over, the tsunamis, right? All that good stuff. All the stuff we see on TV. Okay. Obviously, we talked about war, loss of loved ones. This lady, like I said this morning, is going to have an unfortunate memory of watching us try to work on her husband in her living room, and it may or may not cause PTSD depending on how she deals with it, right? But so, and they're finding out that stress, obviously, now it's called stress disorder, but certain stressors can also be traumatic for people. All right, doesn't always have to be one event. It can be more than one. It can be a series of events. Okay. Um, it's estimated 8% will experience some form of PTSD in their lives. It's all about how we cope with it, how our coping mechanism is around us. Okay. Obviously, military personnel who experience combat, those are things that stick with you for the rest of your life. All right. We talked about chapter 2, how EMS, fire, and police, right? We have a different level of traumatic stressors in our lives, things that we see. All right. That may not be as bad as military personnel, but it's going to be more than what the normal person sees on a daily basis. Okay. So it all adds up. All right. Again, PTSD is going to have some of the same symptoms almost as suicide patients, right? That's why we kind of talk about them at the same time. There's that feeling of helplessness, anxiety, sometimes anger, a lot of times fear, right? Almost like paralyzing fear. Okay. Um, they will avoid anything that triggers that event or a memory of that event. So, like if it's a fire or like a burning smell, right? They'll stay away from fires. Any type of loud noises or bangs, uh, right? For the combat veterans, I have one of my partners out in Dover is a Marine. He's in the reserves, and I don't think he's seen combat, but apparently he must have had something happen in basic training because he was sleeping on the couch, and one of the guys and came in quietly and then sat down and like dropped his bag. That's all, and it just made like a bang on the floor or whatever. And he reached up and swiped, like he was grabbing his gun and was like, and up, and he was ready to like butt smash this guy in the face. Like, and then that's it. And I was like, hey, calm down. You're good. We're okay. He's like, oh, he's like, what was that bang? I was like, just him. He dropped his bag. And I was like, you need to be more careful. Right. And I explained to him why, because he's a newer EMT. He doesn't understand. But, you just have to be careful. So just be aware that, these people, when surprised, their first instinct is to get up and fight. All right. So if you walk in to a combat veteran's house and they don't know you're there, you better be ready. All right. So depending on what combat they've seen, all right, is gonna determine what type of disease processes they have. Unfortunately, like those people who were involved in Vietnam may or may not have had exposure to Agent Orange. Okay, so they may end up with different diseases than people who, went through Korea, went through Afghanistan, Iraq, and all that other stuff. Okay, but apparently they're prone to heart disease, diabetes, and obviously being involved in combat, they are a higher incidence for TBIs. Um, Also, obviously, amputations, everything like that.
But what is Agent Orange relevant to? What is that used for?
So, Agent Orange was a biologic agent that has genetic, um, like mutation properties that they would drop in little like clusters, almost like napalm on villages. And
It was a chemical defoliant. It was used to take the leaves off of trees so you could um, see the
yeah,
target.
I mean, that's what they made it for, but that's not exactly what it ended up doing. So Dave said it's a chemical defoliant, and basically it would take the the leaves off the trees so that they couldn't hide anywhere. But where this is what it would do to the people. That's not on that side, right? Nope. Okay. So we got to slide this way. And now I got to try to work it like this. All right. So you can see in these pictures down here, like these are people who lived through it. All right. There's genetic disorders that come from it and stem from living in the area where it was dropped. All right. And these are basically all over these smaller villages in that area. All right. But it's highly contagious. It has, um, like you don't want, usually they will tell you that they were exposed to it and it stays in their blood. And then you don't want it in your blood because it will be passed on to your offspring. And that's where you usually will find the deformities. It won't happen to you, but it'll happen to your children. All right. So, but yes, we used it as a chemical defoliant to take the leaves off of the trees so that we could see them because it was the first time they had ever seen guerrilla warfare. All right, it was the first time people were hiding in trees and bushes. So we were like, oh, we'll drop this insecticide on them and we'll take out all the trees and the bushes and then we'll be able to see. And I'm pretty sure they didn't realize that this is the kind of result that it was going to have years later. Right. So, and it can cause a whole host of diseases as well within the veterans, right? But it's not, you see mostly the after effects like in the family. All right. Any other questions on Agent Orange? Or is that enough depression for the day? So, unfortunately, in times of war, we are not very nice. And, sometimes things have unintended consequences. Or sometimes they might be very intentional and the risk reward is acceptable. But I'd like to say people didn't purposely do that to other people, but I have no idea. Right. So when we care about these people, again, right, we're going to be very careful how we ask questions because we don't know what their triggers may or may not be, and we don't want to set them off. All right. We're going to use calm, reassuring, but let them know that like there's an air of who's in charge because they may respond better to that being in the military depending on how long it was or how what for what reason they're out. All right, obviously we're going to respect their personal space. We should ask them if they have anything on them that could hurt us or themselves. All right, a crowd might again be a trigger, so we're going to try to limit the number of people involved but enough that you feel safe. Okay, ask about suicide because it is a possibility. All right. Again, these people can almost use anything as a weapon, so just be careful as to what is around. All right. And we do not try to restrain them because that's going to escalate the problem. All right. It will definitely cause a problem. All right. So just these are self-drawn images from PTSD veterans. Okay. So just know that they may look okay on the outside, but on the inside, they are still trying to deal with it. And again, like I said, back in chapter 2 about um, even our own mental health and PTSD as first responders, like, and how it's the stigma that we are not allowed to like say we need help and everything. Like soldiers have it 10 times worse, right? Because they're supposed to be the strongest and the bravest of the brave. And to admit that there is a weakness like for them is not a thing, right? So we have to somehow be able to let them know that it's okay, right, to share these things with other people and that it might eventually help them. Right, here's another one. All right, so we do have to go over some medical legal things because again, you are the right to consent kind of either goes out the window or is taken from them by the police or by yourself. Okay, so again, we have to really, really make sure that it is an immediate, like life or death medical situation. Okay, and um, I'm not going to say that I have never seen a patient unbuckle themselves at the stoplight and run, like open the door and literally run, but we are not chasing them. Okay, you call the cops, you tell them what direction they went, all right, and you follow them if you can in the truck, all right, but that's why we don't leave people alone. All right, it happened, wasn't at a stoplight, it was at a hospital. I was there to pick up a high acuity transport that was going to a trauma center, and one of our other trucks was there to pick up a psych patient, and they walked him out to the truck, and him and the EMT got in, and then the other EMT came back into the hospital for something, and about 2 seconds later you watch the door open and the patient go running out the parking lot, and about 4 security guards like ran out the door and went with him, right? So again, that person did not feel like they were willing to fight that guy that day, and I don't blame them, right? It's your call what you want to do. Okay. However, if they thought he was gonna run, and he had a history of running, so they probably should have had someone with them, you know, to make sure that he wasn't gonna go. He probably should have been sedated. But again, um, right, if they try to run, let them go. Okay. We're not allowed to restrain them while we are, but you can't literally like hold them in your ambulance. All right. It's not safe for you. It's not safe for them. Let them go, call the cops, follow them in the truck, tell them where they're going. All right. So everything that we do in these matters is going to hopefully fall under implied consent. But again, in order for that to work, you have to be able to prove that they're not mentally competent in order to grant their own consent. All right. And that is where the gray area comes in. Okay. So again, if you're unsure of where this falls, right, call the police. Okay. The police are absolutely allowed to take their rights from them. We are not. All right. So if they want to do the paperwork and they want to file the 941 and they want to, put them in their custody and then we can transport them, then all that consent goes out the window, right? Because the police are taking that liability away from you. Okay. You can call med control, but they're not there. So they're gonna be like, well, if you can try to get them here, that's fine. But like, if you can't, you can't. That's the answer you get all the time. And it's like, well, that doesn't help me, sir. Like, what am I supposed to do? Right. So, um, again, you cannot kidnap anybody, right? That's basically what they're saying. You cannot kidnap, all right? You cannot force someone in your truck if no life-threatening emergency exists. All right. The only time you can do something like that is with a kid, because you can say there were no parents around, and in this situation, any parent would want their kid, at least seen at the hospital to make sure that they're okay. Right. But if they're an adult and they can answer all 3 questions, right, alert and oriented, they can say no. So that's always good to have the cops by. All right. Um, as long as what you are doing is life saving, you're going to be okay. All right. Like the court of law is going to rule with you. All right. However, if you just decide to willy nilly start sedating people, which you guys can't, but even if you just start willy nilly, like start restraining people in your ambulance, all right, you can get yourself in trouble. So don't be afraid to transport these people. Always err on the side of treatment and transport, because until they give us x-ray goggles and I can see that there's nothing literally broken on the inside or hemorrhaging or something, like, you know what I mean? they should be seen, right? Because we have no clue. Just like yesterday, we had a girl. She has developmental disabilities. She's in a home. Apparently, she has a history of um, calling EMS and the police to get out of the house because she gets bored there, right? So she has a negative behavior pattern, and they have a plan to interact with her negative behaviors. Um, so we went, and again, the staff didn't know that she had called us till we showed up, and we were talking to her, and she said she had abdominal pain with diarrhea, and they were like, "Yeah, but you had that last week too, and it got better." And we're like, "Okay, right." And they were like, "But you went to Applebee's last night. You had fast food." And I was like, "Well, did she have fast food the last time?" And they were like, "Yeah, I think she did." And I was like, "Okay." I was like, "Point to where it hurts." And she points right up under her ribs, like right here on the right hand side. And I was like, "Okay." So 2 times she ate fast food, 2 times she had diarrhea, and she's having abdominal pain. I'm like, kind of sounds gallbladderish to me, right? That's where my brain goes. So I'm like, all right, we should probably take her in, let her. They're like, oh no, she's not going. You can't take her. And I'm like, what? It's like, but she's no, she's faking it. She's acting out. We can do it here. Like, we're gonna do our plan, and then if it gets worse, we'll go. And I'm like, I get it, but like, there's actually almost a causation at this point, and like a reason that she should probably get checked out. Um, so then when staff said no, she literally the first person, closest person next to her was one of the staff, and she yanked a whole handful of hair and like yanked her across the couch and like bit her on the shoulder. And then I was like, yep, now we are going because now she's like assaulting people. And so we put her in the ambulance, and then the staff, the whatchamacallit, um, management called, and they were like, you cannot take her. You better take her out of your ambulance. And I was like, she just physically assaulted 2 of your staff. I go, and I'm pretty sure she has a gallbladder issue that should probably get checked out. And they were like, no, this is a behavior problem and we'll take care of it. And I was like, so you want me to put her back in so that she can assault your staff for the rest of the day? Like, because that's basically, and the one staff member was like, yeah, this is what she does. I was like, and now she'll just assault us for the rest of the day until she's tired of it. And I was like, so, but apparently the manager came and literally yanked her out of the ambulance and walked her back into the house. And that was the end of our day. And I was like, oh, okay, so this really is actually happening. I was like, well, I'm going to need you to sign here saying that you're going to assume liability if it is a medical problem, and we'll go there. But you know what I mean. But like, so that's the type of things you're going to face. All right. So if I had not actually paid attention, right, to the story, you know, maybe she does, maybe she doesn't have a gallbladder issue, but that's kind of what it sounds like, right? If she's eating fast food and having abdominal pain, having diarrhea, having pain right up under here, you know, that to me is on the right hand side is gallbladders. So who knows? All right, take 5, and then we'll do lady part problems. All right, this one's real quick. I think all we got to talk about is PCOS and something else. Yeah, guys have any questions on behavioral stuff? No. Joe looks like he's getting ready for a nap. I kind of hate doing it this way because we can't even break up the boring stuff with the fun stuff like doing labs. It's like literally the last like 8 classes are going to be fun because it's just going to be all lab time. Huh? You don't think they're fun? Oh. Oh, you're okay with having fun. I got you. Well, I asked her, I'm like, I don't really know how to make this stuff interesting. Like, I have to figure it out. I want to start building those crazy, like, homebrew science experiments to show like how the lungs inflate and kind of stuff, like soda bottles and stuff, and bring that kind of stuff in. But like, I don't know how to make behavioral emergencies fun other than bringing someone in with schizophrenia and not having them take their meds for 3 days and run around in the class. Be like, and this is what happens. Go chase them and figure it out. Like, you know what I mean? Like, I don't. There's no way. I mean, I guess there is. We could figure it out. Right?
And trust me, even when you're in the middle of it all, it's really not all that fun to begin with.
No, it's more of a headache than fun. But I just meant breaking up the monotony of, like, slides and lectures, and kind of like how we did
Ah.
Jeopardy for chest and abdominal trauma.
I was about to say all the last chapter did was just like, yep, work.
Yep,
Sounds-
work.
mhm.
It feels like I do this on the daily. See, but you're gonna have a head up though, like a leg up or whatever. Like, you'll be good when you get those calls.
Oh yeah, like those are my favorite calls to go to because I've dealt with a lot of it already.
So do you know what skip is?
What do you mean by skip?
I don't know. Like the lady at this place yesterday kept saying, like, I'm the only one who's skip certified. And I'm like, oh, okay.
Skills in
So
crisis intervention and prevention, right?
yeah, it
know.
sounds
Why do
like
you know
crisis
this?
intervention training.
Because I used to work in a group home.
Oh,
Okay, yeah, we have it. It's called CIT.
okay. Yeah, theirs was skip certification. I guess it's a special kind of, like, behavioral, like, and it was whatever. It's some kind of program that this one girl is,
Yep.
and that's her.
It typically starts with the, verbal counseling. You try to talk them down and it
It's
progresses.
an 8-hour class.
It progresses through to holds and restraints that
Yeah.
you use to mitigate situations.
And then they teach you all the fun stuff you get to do.
I mean, is it fun though?
Sometimes,
Right?
sometimes it's fun.
Joe's like, you just said it wasn't fun.
But a lot of the focus, at least in CIT, is that restraint is a failure of care.
Yeah, I don't believe in
Which
restraints.
in some situations I think that's a total crock, but that's just me.
I feel like that's the cop out way of trying to not deal with the problem, is just to restrain them and let them, like, lay in bed for whatever, you know what I mean? Or same with nursing homes who just over medicate patients so that, because they're, they want them to go to bed for an hour. But which is why, for the most part, unless they're going to hurt somebody, I refuse to sedate people, because I don't think that's the answer either. Plus, it's a little disorienting when you are at home and then you wake up in a hospital with, like, 2 nurses and a doctor standing over you, and you don't understand how you got there. Like, that's not helping the problem either. All right. What time is it? Oh, 7:44. We could be out of here by 8:30. All right. So we're going to change gears and we're going to talk about female emergencies. All right. Unfortunately, they do have a couple that we do need to be aware of. And we can do kind of very limited treatments in the field for, but we can kind of manage them a little bit. All right. So we're going to talk about the anatomy, because that's going to lead us into OB and neonatal, which should be our next chapter, I think, that we're going to do. So there is the simple version of the female anatomy, right? So the perineum is kind of important. It's the space between the vagina and the anus. It sometimes, will either tear during childbirth and or get cut, depending. So you will have to be able to recognize that and know where that is. Obviously, the anus and everything else that we know about the vagina is the birth canal or the opening. there is a urethra just above that. Okay, and there are folds of skin that surround and protect everything. All right, so the ovaries, right, are the female reproductive organ. They're in the each side of the lower abdomens. All right, they produce eggs, which are caught by the fallopian tubes. Right, the fallopian tubes catch them and then pass them down into the uterus, where they may or may not get fertilized. Right. The narrowest portion of the uterus is the cervix. The cervix opens into the vagina, and the vagina forms the lower part of the birth canal. Right. So here is pretty much the process. Right. The ovary expels the egg. All right. The eggs get caught, moved down, and they get fertilized. Okay. So there's two different things, right? There's ovulation and then there's menstruation. Okay. The onset of menstruation is called menarche. All right. So it's usually, hopefully, between the age of 11 and 16. It seems to be getting younger. Every year it seems to get younger and younger. I don't know what's going on, but it's probably the hormones that we put in our food. But so, right. So women will continue to ovulate and menstruate and be fertile until menopause, which usually will occur somewhere. The median age is around 50. It can be shorter or earlier. It can be later. All right. If they're 71 and they tell you they're bleeding vaginally, it's a problem. All right. That's why we're doing this chapter. Okay. So, again, each ovary produces an egg in alternating months. It's called ovulation. So if the left side goes the first month, then it's the right side, and they go back and forth. Right. Fertilization begins when sperm are deposited into the vagina, right? That passes through the cervix into the uterus. Hopefully, fertilization happens in the fallopian tubes. Sometimes it'll happen in the uterus, depending on the time of the cycle of the female, right? And then the fertilized embryo will travel into the uterus, hopefully attached to the wall, and turn into a fetus, right? So if there's no fertilization within 2 weeks of ovulation, the lining of the uterus that gets thicker in order to prepare itself for implantation will start to slough off, right? And menstruation occurs, and that is basically all of that extra lining, all that extra tissue is what comes out, and you may or actually may not see the unfertilized egg as well. So what type of gynecologic emergencies are we really worried about, right? So we're going to talk about STDs, and we're going to go all the way up to sexual assault. All right. First one we're going to talk about is pelvic inflammatory disease. Okay, this is an infection that usually happens in obviously sexually active women. It can result in ectopic pregnancies or sterility, which, well, sterility is not painful, but ectopic pregnancies are pretty painful. And it will most often be very lower abdominal pain. Okay. Then it leads into STDs, which, can lead into pelvic inflammatory disease, right? So we have chlamydia, which apparently is the most common one these days. It's bacterial. You may or may not have symptoms from it. You may not even know you have that one. Okay. It can go into the rectum. All right. Depending on what type of uh, what type of menstruation products you use, right? That discharge can go downwards and be reabsorbed into the rectum, right? Or it can go upwards into the pelvis and turn into PID. Okay, there's another one called bacterial vaginosis. Is most often the most common vaginal infection. It gets everybody from 15 to 44. All right, and then your normal fauna in the bacteria, okay, in the vagina are replaced by other harmful bacteria that overgrow. All right, so left untreated, it will progress to premature birth or again PID. All right, and then there's gonorrhea. All right, so this one is more inside, right? It grows, multiplies rapidly in warm most areas. The cervix, the uterus, the fallopian tubes, both urethras in men and women. All right, it can spread through the bloodstream and go to other parts of the body. Okay, so basically, what are we going to get called for? Right, we're going to get called mostly for abnormal vaginal bleeding. All right, which can be anything from early menstruation to heavy menstruation to even abdominal pain with like lack of menstruation. Okay, vaginal trauma. All right, ectopic pregnancies, like I said, are pretty painful. Spontaneous abortions. Sometimes it just happens, and we'll get called PCOS now. The cervical polyps and or cervical cancer may cause bleeding. Okay, so but they'll have histories usually involved, and when you're doing your assessment and everything, you'll find all that stuff out. So basically, what are we as EMTs going to do? Right, this is sort of a private kind of situation, right? We're not really going to expose everyone in public, okay, to see what's going on. So again, patient privacy is of the utmost importance. All right, so again, if you have a female available, allow the female to help. They have a better understanding, obviously, sometimes than we do of what's going on. So, and another female may be more comfortable with another female there than a man trying to take care of them. Okay, so do whatever is best for the patient, do whatever is most comfortable for everybody involved, right? Again, we do carry sanitary pads on the ambulance. All right, if they don't have any, or if they keep saturating their own, right, take the old one away and replace it with a new one. They are very rich in nerves. Okay, so everything, especially when there's blood flow going in and through that area, everything becomes more sensitive. All right, so any type of injury or whatever is going on becomes even more painful. All right, so just be mindful of that when you're moving them or doing things. Okay. Any type of lacerations or any type of injury, okay, if there was self disfiguration, right, or an assault or something, okay. Moist sterile compresses, we do not pack or place anything inside, right? Use the sanitary pad. And that's it. It's basic. Treat for shock if there's extreme blood loss, right? Oxygen, blanket, be compassionate, position to comfort, right? So with PID, it's all about pain management, basically. Sometimes they can, sometimes they can't walk. So, you're gonna have to work within what your patient is allowed to do. Again, there's not much we can do for it. Again, some people will give them pain management, some won't. All right, so you can call for it, but it's going to depend on the medic that shows up. All right, most often that kind of stuff is going to go BLS as long as their blood pressure and heart rate's fine. Okay, so we'll talk about sexual assault, and then I think we're done. All right, so 1 in 5 women report being raped, right? And 1 in 3 women will report being sexually molested. Okay, and there are a lot of issues that will face any type of really sexual assault. All right, because now there may or may not be any trust in anyone. Okay, that so um again, depending on who called, how long it's been, how far away you are, you may or may not be the first person to come in contact with them. All right, so you have to be super professional, right? You have to be extremely sensitive, kind. All right, it's not their fault, right? There's nothing. It's almost going to be 2 chapters at once, right? You're going to have trauma involved possibly, and you're going to have some sort of behavioral slash emotional reactions. So you gotta have both hats on, and you gotta treat both equally important. Okay. There are drugs out there, right? Obviously, so be careful. If anything was used, or if you suspect anything was used, or they say like I woke up here, okay, it's now all a crime scene. All right, so don't be careful what you're doing. Like call for the police. All right. Again, if there's a female, right, they may not want to see a guy right now. Okay. So just be careful. Um, again, like I said, we're there for medical, we're there for psychological, right? So you have to treat both. However, you also have to preserve evidence. So we're not really cleaning anything, okay? Because there's genetic material from the other person, possibly. All right. So the cops are going to want their clothes. Okay. The cops are going to want everything. Um, hopefully you can get them to go in to get, like a rape kit done. But you're going to want histories. Okay. And you want to be as detailed as you can be, even though you're asking them to relive probably one of the most horrible experiences in their life. Right. But try to work within as much as what they will give you versus trying to force stuff out of them. Right. So here's another table out of your book. All right, we're going to document everything, right? Because this is all part of the patient chart. This is going to be all part of the, more often than not, the lawsuit, okay, or the court case, right? So everything, document history, assessment, treatment, response, anything you did, okay? Again, there should be no speculation in any charting that you do. All right, you will only ever chart what you know, or you're going to use the words possible, like if you're talking about like diagnoses or something like that, like patient was possibly assaulted, right? Because we don't know, like the person's not there, right? So we don't know, or patient states she was assaulted, right? But don't say patient was assaulted by a 34-year-old male if she didn't tell you that, right? Because we don't know. All right, we're gonna do the sample, okay, as the best that we can. Again, it's a crime scene, so usually one person in, one person out, right? Because you want to limit the number of people that are either involved and or may cause any disturbances in evidence collection. All right. Again, uh, if you can get them undressed, or if the police get them undressed, they'll wrap them in something, right? And then we will wrap them again and take them outside. Right. Do not take anything out of where it is if something is there. Okay. And again, we're not disturbing anything unless there's some sort of life-threatening or major bleeding that we have to control, right? Because all of that stuff is all evidence. All right. Again, confront their psychological needs, hopefully by using the same gender, or find someone who's a very reassuring person of the opposite gender that can help. All right. A lot of times their first instinct is going to be like bathing, going to the bathroom, cleaning themselves up, Okay, and that, as hard as it is to try to tell someone not to, all right, we kind of gotta make sure that, you preserve whatever evidence is left the best you can. Um, all of the evidence goes in a paper bag. All right, so if they do start handing you clothes, try to find a paper bag in the house because we don't carry paper bags on the ambulance and they're not allowed to go in plastic. Okay, so I knew you were going to ask me, and I don't know. I don't know why they can't go in plastic. Mark, do you have any idea? No, I don't. I didn't think you would. I was just kind of just kind of hoping maybe. Uh, yeah, I don't know. I know I did it one time, and the nurse freaked out at me when I got to the hospital, like because I put it in a red bag because that's all I had. I don't have paper bags with me. She was like, "Well, you should have put it in a blanket then." I'm like, "Okay, now I know. Like next time I will. Thank you." Right. So yeah, use a sheet or a blanket instead of the plastic. I really don't understand the whole not plastic, like the paper, but like they were. It should be in a paper bag. All right, but you should have police around, and if they start taking clothes off in the ambulance, ask the officers for paper bags because they carry that stuff. All right, specifically for this kind of stuff. Um, again, if they have to go to the bathroom, don't let them go in the toilet. Right, use a urinal, use a catch-all, use something. Okay, and then right, the toilet paper goes in the paper bag. Okay, because all of that genetic material that may be on the toilet paper now goes in the bag with everything else to get tested. All right, and then make sure the bags are always sealed and labeled. Medical tape, right? Tape it up around, fold the top over, tape it, label it, initial it, date it. Okay. That way it's all chain of evidence. All right. And then I don't know if we have any specific sexual assault nurse examiner sites here. Um, or if all of them are. I don't I don't know. I would have to let me see if I can look that up real quick. There are not a lot that we do here that I'm aware of. I think I've done one in the 6 years that I worked in Dutchess County. And that was the one that I got yelled at on because of the plastic. Scene hospitals, a list of every. Oh no, that was someone looking for information. Oh, that is a that is a lot of that is a lot of hospitals. What's this one? The Reach Center Incorporated. Looks like Albany Medical Center has one. Samaritan has one. I don't think there's anything near us though. Nope. Orange County has one. Westchester Medical has one. Why does Connecticut Children's Hospital have one? That scares me a little bit. Yeah. So it looks like the closest actual sane program around is in Albany, even from here, or Westchester. Well, Westchester is probably closer to here, right? Than Albany. I mean, you can take them to Northern Dutchess and or Vassar and or Mid Hudson. Okay, but in actual like certified sane examiners are in Albany or Westchester. That's good to know. I actually didn't know that. And we're done. Do we have any questions? Anybody have questions on anything? Everybody's good?
Yep.
Only question I have is the paper
Yep.
and
Yep.
plastic thing, but I'll Google it.
Oh, yeah, let me look up the paper and plastic thing real quick. Paper bag versus plastic bag. Evidence preservation, let's see. Write down if you choose, avoid drinking, bathing, showering, brushing, mouthwash, combing, do not change clothes. It just says a plastic bag may destroy evidence. Let's see. Let's ask Google a better question. How does a plastic bag destroy evidence? Why evidence collections? You too. It just says paper bags are best for other evidence such as blood, saliva, semen, or other bodily fluids. Work well for both fresh and dried blood or semen stains. Also useful for storing fabric and textile evidence because air permeability is beneficial with this type of evidence. So it's gotta be
So,
because of the air, like the air going through.
yeah, from the quick search, it says each item is placed in a separate paper bag to prevent cross-contamination. Plastic bags are not used because moisture can collect within the bag and alter the evidence. Do not remove attached hairs or fibers from clothing.
Right, so it's a moisture, right? Yeah, that makes sense.
Yeah.
All right, sounds good. Any other questions? Oh, Neil must be back on campus. He's actually in the Zoom meeting. Yeah. So it's the air permeability and yeah, basically what Taylor said. The book says paper bags allow wet items to dry naturally, whereas plastic allows mold to grow and may destroy biological evidence. All right, sounds good. Anything else before we go? All right. If everybody's good, I'm good. You guys have a good evening. Hopefully I'll see you guys next week. You guys should be on campus now, right?